Welcome everyone to CVI Now's live virtual event about diagnosing CVI. If you're with us on the CVI Now parent group, drop a hello in the comments and feel free to post questions as they come to you, which I'm sure many questions will come to you as you listen to our guest speaker today. I am Rachel Bennett, the Content and Community Manager for CVI Now, and I'm a parent to a child with CVI. Today we're talking about diagnosing CVI and the medical perspective of CVI. Children with CVI are misdiagnosed and underdiagnosed. Many CVI families have a common story, a story of how CVI was missed by medical professionals and other providers. But there are medical professionals that know CVI well and know how to thoughtfully diagnose CVI. And there's growing awareness of CVI in the medical community. So I'm thrilled to introduce our expert today. Dr. Nicole Ross is an attending optometrist for the NECO Center for Eye Care and also at the Perkins Low Vision Clinic. She is an associate professor of optometry at the New England College of Optometry. Dr. Ross has authored several research papers, abstracts, and co-authored a textbook chapter on stroke rehabilitation. CVI families praise Dr. Ross for her thoughtful, detailed, and comprehensive evaluations of patients with unique vision needs, including CVI and ocular conditions. Today, Dr. Ross will be discussing diagnosing CVI, intersection of CVI and ocular clinical assessment. And after a presentation, Dr. Ross is here to answer your questions, ones that were already submitted and ones that come up live. So let's turn it over to Dr. Ross. Welcome.
Thank you so much for having me, Rachel. So I'm just going to share my slides here. All right, can you see my slides all right?
Yes.
Okay, great. So thanks for having me. As Rachel mentioned, my area of interest within the realm of optometry is in working with patients with low vision and vision impairment. And within the field of low vision, we started to define visual impairment to describe the measured visual functions of the patient. So their visual acuity, their contrast vision, and other such measures that we get from our specialized testing. And then we also refer to a person's functional visual ability to describe their limitations or some of the difficulties that they're facing to perform visually mediated tests as a result of their vision impairment. And so as you can imagine, the field of low vision is tremendously interesting because everybody's experience is tremendously personal to the task that they need to do and to the condition that they have. And so the functional consequences of vision impairment are really multifaceted. And they're also, influenced by any other conditions or comorbidities that the patient may have. And a team-based approach to care is usually required. And so my role in this team is really to identify possible medical interventions that may be available to reduce the level of vision impairment. And when that's not possible, to seek ways to improve the patient's functional visual ability. And that might include different visual assistive equipment or devices, environmental modifications, or other compensatory strategies or techniques. And sort of these approaches aim to reduce the functional demand of a task and improve the patient's functional ability, and really has to be individualized and customized to that person's needs. So that's a broad overview. And, certainly one of the conditions that many of my patients have is CVI. And today we want to sort of focus our discussion on that. And so I want to review some definitions of CVI, which perhaps this group may have been, well aware of already. So I'll try to just give a very cursory view and apologize if it's repetitious, but also discuss, the clinical low vision evaluation and understand sort of the visual processing and perceptual difficulties that are associated with CVI, and what are some of the roles of questionnaires and other clinical and educational assessments in making the diagnosis. So some really helpful resources that are out there that you could take a look at is teachcvi.net, which has a lot of research resources as well as some questionnaires that are used by many clinics. CVIScotland.org certainly has a great resource on simulations of cortical vision impairment and resources for parents. And of course, your website, CVI Now by Perkins. And so let's go into our discussion of CVI and maybe more specifically how our understanding of CVI has evolved. So in discussions of CVI, you may notice that people are careful about saying cortical versus cerebral visual impairment and what the C stands for. Certainly in the very, classical and specific sense, cortical vision impairment implies to damage of the optical pathway after the chiasm. So that's the point in which the two optic nerve fibers sort of cross in the brain and then go to the occipital lobe. And so some of the characteristics of post-chiasmal CVI are visual field loss, behaviors of light gazing or difficulty engaging with visual stimuli. We notice that some patients may have better visual attention for a moving object instead of a static object, familiar versus novel objects, and simple versus complex environments. Sometimes we also note patients having difficulty with reaching and grasping, poor social gaze, difficulty integrating more than one piece of sensory information. So for example, can't look and listen at the same time, and delayed visual responses. Sometimes the C refers to cerebral, and cerebral vision impairment refers to the damage to the areas of the brain involved in higher order visual and sensory processing. So characteristics are, complex processing difficulties, dorsal or ventral stream dysfunctions, which we'll talk more about. And students often need simplified learning environments or materials in order to navigate and engage with their environment. And so all of this is, a bit technical, but sort of our working definition of CVI in terms of the educational realm is, very comprehensive, including both cortical and cerebral vision impairment. And so the C is, including both things. And in the educational realm, we're thinking about CVI defined as vision impairment that's due to dysfunction of the optic, radiations, visual cortex, or both. It can coexist with other ocular and oculomotor disorders. And certainly it's about 30 to 40% of kids with vision impairment have CVI. And so I like this sort of broad encompassing definition because it really is very inclusive of all patients that have visual difficulties due to brain-based vision impairments. And I think it's very important to recognize that while patients may have, specific ocular pathologies, that doesn't necessarily mean that they don't also have cortical vision impairment as well. And so some common etiologies of CVI, looking at records presenting to the clinic at Perkins and also other published papers, certainly common conditions and causes of CVI have been noted, such as premature birth, periventricular leukomalacia, which is a specific white matter brain-based condition, hydrocephalus, the occurrence of reduced oxygen or hypoxia perinatally, ictal or post-ictal blindness, so visual difficulties associated with seizure disorders, cerebral palsy, and other genetic syndromes. And certainly as our recognition of CVI in the medical field has come to the forefront, more and more etiologies are being identified. In terms of the spectrum of visual findings that we find in patients with CVI, Fawzi and her colleagues produced an excellent paper looking at the records of patients presenting to their clinic. And so 121 patients were included in this review. And they found that 87% of the patients with CVI had some reduction in their visual acuity. Just under half had some reduction in their contrast vision. 73% had a normal OCAN response. And so that's a visual reflex that it was noted to be abnormal. Visual field loss in 6%, strabismus or an eye turn in 73%, and abnormal ocular motility, either in fixation, tracking, or the ability to look at one target to another. So there's a wide spectrum of presentations, as you can sort of appreciate. And sort of how I think about CVI is that the patient has visual symptoms at the top here, but those can be broken down to, primary visual disorders such as, a visual field loss, reduce in acuity, reduce in contrast vision or color vision. And these sort of primary disorders are really readily picked up on, your first routine eye exam. And then there's these other secondary disorders that are associated with CVI. And these secondary disorders probably represent most of my patients with CVI. And these are patients who have difficulty with visual attention, recognition, interpretation, or they may have difficulty with motor planning, ocular motor eye control, and difficulty with sensory integration. And so these secondary disorders, although they're more common in CVI, they're a little bit more difficult to identify. And, as eye care providers, we don't always sort of pick up these secondary things on the first exam. We sort of have to do the first exam to identify if there's any sort of primary disorders. And then once that testing is complete, then we can sort of go over and consider these secondary issues. And so looking at these secondary issues, these are really difficulties and really involve the dorsal and the ventral pathways in the brain. And this is a diagram from Dutton that you may have seen before. And so the ventral stream in the brain, in terms of interpreting what we see, involves the recognition of objects. So this involves the occipital and temporal lobes and involves tasks like recognizing faces or recognizing familiar objects or learning to identify objects. Whereas the dorsal stream pathway in the brain also involves the occipital lobe, but involves the parietal and frontal lobes. And this is how we integrate sensory input with attention, integrating sensory input during a motor task, and how we manage visual complexity, because not all of the visual tasks that we're asked to do are like an acuity chart with a black letter on a white background. There's lots of other things that we have to interpret simultaneously. And the dorsal stream is also involved in our motor planning, our head and eye movement, our visual guidance of movement. And so what I hope you can appreciate is that there's a lot more involved in seeing than just the eye and the occipital lobe. Over half of the brain is dedicated to the interpretation of visual information, and different pathways are involved in that interpretation. And so Gordon Dutton in his book really was looking at the ventral and the dorsal stream because he was trying to categorize his patients. He was trying to understand what the trends were in patients with CVI. And so he sort of developed this sort of tree of vision to understand how can we sort of characterize the different trends that we see in patients with CVI. And, most notably, we see patients who have difficulty with recognition tasks. And these are patients who have, ventral stream difficulties. And then there are patients who have, dorsal stream difficulties. They have trouble with visual complexity, visual motor tasks, and integrating visual and sensory information. And certainly there are patients with difficulties in both of these areas as well. So how do we go about asking patients about sort of these secondary visual difficulties, these difficulties that involve more than just seeing the eye chart or a visual field test, but have to do with how they interpret visual information? And as you can appreciate, that can be rather difficult, but it really starts with a very careful history. And so the history, I think, is a crucial part of identifying visual difficulties that may be attributed to CVI. And, when we're thinking about that these issues may be an issue for patients, we really want to know the child's developmental history. We want to know their visual behavior. We want to know their habits, their preferences, their difficulties. What do they avoid? What do they like? When they play, is there any visual curiosity? What about their social behaviors? And, during the history, we're pretty careful about wanting to know more and more and as much as information as we can about this child or individual. And so, and we also want to keep in mind that we may have to adjust our exam room so that we can take that history appropriately. Many patients with CVI have difficulty with clutter. So trying to keep a space for a patient interview that's clean and tidy so that they're able to participate and less distracted. Certainly having a calm voice, involving, the child whenever possible to ask about their own experience as well as that of their siblings can also offer useful insights. We try to be structured about the questions, asking open-ended questions in a neutral tone, maybe asking some clarifying questions, but we want to sort of avoid sort of narrow questions with yes/no responses. So again, that we can gain the most information possible. And so in terms of the stages of the clinical interview, as Dr. Dutton describes it, we want to seek the history. We want to sort of clarify, ask patients then to expand, give examples. We really want to sort of ask enough questions so that we can sort of determine, are there patterns of visual behavior? And we also want to, understand this better so that we can characterize the patient's visual difficulties. And a lot of the times we actually use a structured questionnaire for this. And the reason being is that it's a reliable way of gaining history information in a method that's standardized, that's open-ended, that's not leading, and that we can, make sure that we are asking all the questions that may be relevant during a clinical exam. And so the first sort of survey tool that was developed for clinical use was Dutton's survey or inventory that has 51 questions and explores and asks questions about visual difficulties in a lot of different, functional domains: visual recognition, attention, perception of movement, complexity, and so on. And later, Orbitus developed a screening tool that was a little bit more focused, and there were 3 different questionnaires that were made available that were more tailored to children in certain age groups. And similarly to Dr. Dutton, sort of each question sort of kind of focuses on some different visual domains. So asking questions about a patient's attention, their fixation, asking questions about difficulties with recognition tasks, difficulties with visual complexity. Do they get overwhelmed when there's a lot going on? And then also asking questions about visual motor and movement. And so these surveys have been a very helpful tool to many clinicians because they allow the careful collection of history. They allow us to make sure we're being comprehensive in asking questions about all of the different, secondary visual difficulties that many patients with CVI have that may not be easily identified on, our basic clinical tests. And they also, there's been a lot of research done to look at, are there certain questions or areas that are more predictive of CVI that we should be pertaining particular attention to? And while these questionnaires aren't, in themselves diagnostic, it's not like if you get a certain score on the CVI questionnaire, that's it, you have CVI. It does require some professional judgment and interpretation because, some difficulties could be due to another cause and not CVI, but it does allow us, again, to be comprehensive and allows us to really spend time thinking about these secondary visual disorders that are really common to CVI that may not be always readily identifiable on a basic vision test. So once we kind of got through that stage, we really want to explore, how do these visual difficulties impact the child and the child's family? What is their previous history in terms of what have they been told by other professionals? Have they seen neurology? Have they seen ophthalmology, optometry before? What are the wishes, concerns of the family and the child? And, most importantly, we want to make sense of this information, and we want to see where there is cross correlation of the reported behaviors to what we can see in our interaction with this patient. We want to sort of be in a position to assemble the history, start drawing some conclusions, and really use this information to guide further assessment. So after I take sort of an inventory or history or questionnaire, I'm really looking at, okay, well, what is in the report from their other providers that is sort of consistent with some of these complaints and concerns that we've identified? What's not consistent? What are the trends that are starting to develop? And what other sort of testing should I be thinking about in order to better understand this patient? So to give you a few examples, if I think about something simple like testing a patient's vision and having them read the eye chart, depending on how they answered the questionnaire, I might look back to those previous eye reports and think, well, how did they perform on this test? How was the measure obtained? Did they just show a single letter? Did they use a preferential looking test? What was the environment like? Was it just a dim room? Was there a lot in the room? Was there task lighting available? I might also think about, what about crowding and a crowded visual acuity? So sometimes we measure visual acuity with these crowding bars, or we can measure it with a line, or we can measure it with a full chart. And crowded visual acuities can be particularly difficult for patients who report difficulties with visual complexity. So this is a classic example of crowding. And so in this diagram, you're actually to look at the dot in the center. And while you're looking at that green dot in the center, you probably can easily identify the A on the left-hand side, but over on the right-hand side, that A might be a lot more difficult to identify because of all the other stuff around it. And that's an example of crowding. And crowding, as I mentioned, is a common problem in CVI, but it's also a problem when we have a patient with a lazy eye or an eye turn. Crowding can also be a problem when patients have macular disease and they're using their peripheral retina to see. And as I mentioned in CVI, crowding is an issue because it's a source of visual complexity, which is really difficult. So we want to sort of think about, how was the information collected before? If it was collected, very simply, just a single letter on a white chart, and the patient's reporting a lot of difficulties with visual complexity, I might want to see how they do on a more crowded chart and compare and contrast that performance to see what is the difference, and does that correspond to some of the challenges that they're reporting. There's been a lot of, there's some studies actually on crowded acuity and CVI. One that was published in 2016 in the Journal of Optometry, which found that children with CVI often had a crowding ratio greater than 2 or 3 times. So meaning their performance on just a simple visual acuity test was 2 to 3 times worse when there was crowding compared to if it was just a single letter on a white background. So that ratio between the performance on the 2 tests was 2 to 3 times worse. Now, as I mentioned, many children with CVI also have strabismus and eye turns, and crowding is also a problem when you have an eye turn. And they found that, well, if you had a child with an eye turn without CVI, we can expect their performance to be decreased by about 1.5 times. So the crowding is a more significant issue for a child with CVI than for a child with just an eye turn. And so that can kind of help us differentiate, is all of the visual challenges that the patient's having due to their eye turn, or is there something more here also going on? And there's been other studies that also noted these difficulties with crowding in CVI, looking at this crowding ratio. So that can kind of be helpful to sort of understand how does that history correspond to the patient's visual function and functional ability. Difficulties with visual spatial tasks are often a common area that patients report difficulty with. It's another sort of secondary visual disorder that is sort of can happen in patients with CVI. And so sometimes I ask patients to do some puzzle tasks for me, and they sort of often, the parents and patients look a little perplexed. Why are you asking me to do this puzzle during the eye exam? Do you just want to take a break, or what are you thinking? And the reason I want them to do the puzzle is I want to actually sort of compare if I had, a simple shape puzzle, very high contrast, is that easy to do? And as I make things more and more complex, give you less tactile feedback, less color information, and so on, does that get more visually difficult to perform? And how does that compare and contrast with the information that we gained in the history? It just allows me to see in real time sort of some of these difficulties with visual spatial tasks, and they can be really varied as well. And other things that I might ask patients to do is, looking at difficulties with visually guided movement. So how can they, reach for a target and, do that with really great accuracy, or is that really difficult to do, to point and reach precisely? What about placing beads on a string? That's again, sort of, you have to have good acuity and good visually guided movement. You're moving and seeing at the same time. Is that sensory integration really challenging? Going back to the perception of space, do they know their left and right? Do they get it mixed up? Is it really difficult for them to understand where they are in space and how to move in that space? How do they integrate that information? So I guess I'm just going to check if there's any questions at this point, but hopefully I think
so Dr. Ash, there's one question about acuity testing. If you can explain how you use the Teller acuity cards with your patients.
Sure. So with the Teller acuity cards, this is a card that has stripes on one side of the card and then an equal luminance gray on the other side of the card. And for patients, the task is, to see if they are able to identify the stripes. And so as we go into the cards series, the stripes get thinner and thinner and thinner. And so we're able to sort of to determine the threshold of what they see. The advantage of the Teller cards is that the patient doesn't necessarily have to be verbal. You know, if you can recognize the pattern, our tendency is that we like to look at patterns. It's a instinctual behavior that we have. So if we see that stripe pattern, we're going to look at it. Our response might be a little delayed. It might take us some time to get there with certain conditions, but we like to look at patterns. So if I see a patient, I hold up the card, they look at the stripes, I know, okay, they saw it. I might do it a couple of times in different locations just to make sure. But if they look right at the stripes, I can be confident that they saw it. If they're looking back and forth on the card, you know, sometimes to the gray side, sometimes to the pattern, sometimes to the gray side, they're sort of searching, then I know that patient might not be able to identify the pattern because that sort of instinct isn't there. And so, you know, in terms of how we use teller acuity cards in a CVI context is I also want to know and get a sense of that same sort of crowding issue. And with the preferential looking strategy, I can't sort of, you know, put crowding bars around it or make them read a lower letters, but what I can do is I can change the environment. So I can sort of compare, well, how do they do with the lights on? You know, there's some different things in the exam room versus if I turn the lights off and just focus the light just on the card. So there's really nothing else around. It's just the card that's being presented. Then that's somewhat analogous to sort of a crowded versus uncrowded acuity. I can get that same sort of information. So I hope that that answers that question.
Yes, thank you.
So I was asked to sort of think about a case study. And so I decided to sort of make a case composite of, you know, so this isn't any particular person's finding, but sort of a composite of some cases that I've seen recently and sort of some trends that we see. So we'll go through kind of the clinical history process. You know, I'll talk about what, you know, clinical findings support and verify that clinical history and how we then take the next step in terms of communicating to the rehabilitation and the educational team about how that patient needs to be supported. And again, this is no particular person, but a case composite. So we have a 5-year-old female presenting to the clinic with her mom. The mom wants to know and get a better sense of what the patient's vision is now that she's a bit older. And the educational team really wants to know how they can support this person, how they can make improvements in both the home and in the classroom to better support her. And so in terms of the patient's birth history, we know that there was a very complicated pregnancy. She had a normal birth weight and there were no additional complications at the time of birth, but they did note some developmental delays and difficulties with early feeding. The patients that I see often, they have neurology reports that they're able to send ahead of time for us to review. And so we note some delay of speech, some gross motor skills and low tone was noted by neurology, and a diagnosis of cerebral palsy. In terms of ophthalmology visit, this patient had strabismus surgery at the age of 2. She had no eye turn after the surgery, but did continue to have limited depth perception. So on this test called stereopsis, it's a vision test of depth perception, very reduced to 3,000 arc seconds. Normal is about 20 seconds of arc. And it was noted that she had some optic atrophy. So in terms of the social and education history, this patient works with a teacher of the visually impaired, receives OT services as well as O&M services, and speech and language services. I like to read the reports if they're available from the educational team ahead of the visit. And the O&M evaluation notes that the patient's having difficulties in unfamiliar environments more so than familiar, and is having problems with depth perception, particularly stairs. They also notice that this patient is moving their head down while they're walking, and that noises can be, really distractive while walking, that it's really disruptive. They note that the patient needs time to see. They need to be encouraged to pay attention to their surroundings. And, they sort of understand that visual processing may be difficult. The TVI, again, often sends along their assessment, so we can review that ahead of time and get an understanding of the issues. They know that there's difficulty tracking and with mobility. They note the expressive language delays. They make a comment, they observe the patient coming very close to visual information. They can discriminate familiar icons once learned, and can visually discriminate, 1 inch picture icon and 16 inches. And I really love it when teachers of the visually impaired give me that specific information, because I can sort of calculate in my head, okay, I anticipate that patient's visual acuity to be, X. So I really like getting that type of feedback. And I can compare it to how they do it in the clinic. In terms of the teacher also notes that the patient can track large objects like people walking, but doesn't always consistently track, in a more closer space, and that the visual attention can be fleeting, but is better when the patient is doing, a favorite activity. So we have a lot of different ways of measuring vision in the clinic. We talked about teller cards for patients who are nonverbal or have trouble with speech. For this patient, they used one of the Prolo2Go matching programs on the iPad. And the teacher put the Leia symbols that we often use in the office on the iPad already. So she could point to those, and as we went through the shapes, could identify those. And so in terms of the patient's vision, they're measuring 2150 with each eye and 2100 both eyes together. So we know, for reference, perfect vision is often referred to as 20/20. And so when the vision is worse than that, sort of think of it as a ratio. So this patient has to be 5 times closer to something than a patient with 20/20 vision with both of their eyes open. So in terms of other, clinical tests we obviously want to look at this patient's eye alignment because they've had a history of eye turn surgery, and that looked pretty good. Their pupillary responses looked good. We wanted to look at how they move their eyes because we already were made aware that, visual tracking might be a problem. And we note that, the patient can move their eyes fine, but, it requires some initiation of head movement, especially when they're trying to look to the left. Depth perception was a question that was brought up by multiple professionals. And again, we didn't measure any depth perception on our stereopsis depth perception testing. I also like to measure contrast vision because I want to know not only how bold does something have to be for you to see it, or sorry, not how small something has to be for you to see it, but how bold. So contrast measures, how bold do we have to make a visual stimulus in order for a patient to recognize it. And sometimes we do this testing with letters, and the letters fade as you go, or with shapes. Dr. Mayer developed these cards that we call the double happy test. And it's similar to kind of the teller card approach in that one side of the card has the happy face and the other side of the card is blank. And so if the patient's sort of looking back and forth, trying to see, is there something on this card, then we know that they're not able to recognize it. And if the patient looks directly at the pattern, we know that they're able to appreciate that. Or sometimes we ask patients to point at the happy face if they feel comfortable doing that. And so this patient, their contrast vision is a little bit reduced. So for a kid, we anticipate that they would achieve 1.8 log units or better. And so this is slightly reduced at 1.55. We also like to measure visual field, and sometimes not all of our patients feel comfortable participating in formalized testing. So we might use sort of a light stimulus. So this is Leah with her special wand that she developed. So we sort of try to distract the patient to look at our face, and we bring a light from the side and we see, when do they recognize or look at the light. We also have sort of a larger light wand that we often use in the Perkins Clinic as well. And so on this test, we noticed that the patient often is missing, the light when it's below where they're looking. So they're not responding to see it until it's right in the middle. So we really want to understand that patient's peripheral vision a bit better and see if they can do a more formal visual field test for us. So as we follow this patient, one of the first things we do is we want to sort of look at the eye alignment, look at their glasses, look at their depth perception, especially for a patient, who has a history of an eye turn. And when we prescribed the glasses and then followed up the next visit, you can see the vision improved a bit, but the depth perception was about the same. And at that time, we asked them to do another visual field test for us. So I often will use the Goldman visual field test, which is a manual test, but it does involve sort of the same visual field test that most of you probably have taken, where you put your head on a chin rest. There's like a white bowl that you look into. You're asked to look in the center, and we see if you're, when you're able to see a light coming in from the side. And so what we often have are reports like this. So here the patient's looking in the center at this point here, and this line marks, when the patient's able to see the target. So we're bringing it right from the outside, and then as soon as they see it, we indicate that here. And you can see on this test, they weren't able to see any targets, below where they were looking, that was difficult for them. And so this is sort of the normal visual field for this patient's age that we expect in orange. And you can appreciate that, the field is mostly full except for, a really significant difficulty identifying targets below fixation. So if we sort of put the pieces together here, certainly there is a lot going on. There's a complex birth history. There's a relevant neurological history. There's a history of decreased tone that could be contributing to the patient's mobility problems. There's a decreased acuity that may not be entirely attributable to their eye turn or their optic atrophy. The responses in the history aren't consistent with just an ocular motor or just an eye issue. There's difficulty with complexity, there's difficulty with novel environment, with noisy environment. And we also notice that it takes her a little bit a tough time to make a decision on some of our clinical tests. So there's a latency in responses. And so we had both mother and teacher do, our CVI questionnaire. And what was interesting is they both noted, similar trends, that there were difficulties in attention, visual complexity, latency, dorsal stream functioning tasks, and, often stopping an activity when there's too much to look at. And so what were sort of some of our recommendations after, these two visits? Well, We wanted obviously to make sure that we had full-time glasses wear, make sure we've got our basics covered. We know that glasses can help improve the vision somewhat, so we want to maximize that as much as possible. And while the visual acuity of our patient, it might be limited because they have other eye issues going on, we do want to maximize that as much as possible. And we're worried about, the patient developing maybe a possible lazy eye. They've had an eye turn in the past. So we actually talked to the parent about patching, and this isn't an easy conversation because, the patching decision, is really tailored to each specific case. But in this case, we felt that we wanted to give it a go for a while just to see if there was any further improvement in vision that we could make. So we wanted to sort of follow it closely and just to see how things went. And so we made a plan to follow up in 3 months' time. We noted that the eye alignment was pretty good with the glasses on, so that remained good. We noted that the contrast vision is reduced by a factor of 2 compared to normal. And this may explain, some of the visual difficulties that the patient was having in low lighted environments. And so we really want to inform the educational team of that, make sure the lighting is good when we can, and make sure that we're using, bold materials in the learning environment. The visual field loss, the difficulty seeing any targets below fixation might explain why this patient is often looking down when they're walking. This might be an adaptation that they're making because of their field loss. And so we want to alert the mobility instructor of that so that they can start working on other compensatory strategies, maybe incorporating a cane to help detect objects below when the patient's not looking down. We did note that the patient can track, they can move their eyes, but some head movements required to kind of initiate things. So, and we noted that mostly in left gaze. And also when they're looking between targets, sometimes they need a head movement to get there as well. So here there's several, behavioral hallmarks of CVI that have been identified through our questionnaires, through our testing. Things are starting to look pretty consistent. There's some patterns emerging here. And so we really need to make the educational team aware of this so that they can really take in these things into account and adapt the educational plan for this child accordingly. And really, making note that the services that this child is receiving with the TVI, the O&M, and the OT and speech and language therapists are super critical for their success moving forward. And so, as we follow this patient over time, as you can see, in this particular case, and in composite, the vision did improve over time with the patching, and then it sort of plateaued, in which we decided to stop. And the patient's depth perception also improved. So this is sort of, again, a general case example, not, pertaining to any particular patient, but I hope it served as a good example for you to see sort of how we have to work through in a very iterative manner, in a very team-based manner, in order to help kids as much as we can, understand their vision as best we can. And sometimes I hope you can sort of appreciate that sometimes it's difficult to identify the issues right away, but we do want to be consistent with our follow-up so that we can, sort of track how things are going. Is everything explained by the glasses? Is everything explained by what's going on with the eye? Or is there something more here? And certainly, hopefully you can see how sometimes these questionnaires that we have patients do can be really helpful to make sure we've got a comprehensive understanding of the difficulties that patients are experiencing, and that we're really comprehensive with that. Often, visual complexity is difficult for patients with CVI, especially if strabismus is also present, which wanted to bring to you an example where there was an eye turn as well. And these are cases where having educational materials that are, simplified visually, less busy, are really important. And for this particular, type of case, having even the communication board really has to be considered and adapted. Do we need to minimize the symbol array of how much is presented at a time, have auditory enforcement, and so on. And when there's many ocular and medical diagnoses going on within the same patient, we also want to make sure all of our basics are covered. So here we had a patient with a high plus prescription, unequal acuity between the two eyes, and eye turn. We want to make sure that we're doing, all of the basic things that we do with kids to make sure we maximize the vision as much as we can as well. So I'll sort of start taking questions, but hopefully you can kind of see the themes that I tried to convey in this talk, regarding the iterative process that we go through in making a diagnosis with CVI. We may not know all of the answers on the first visit, but we'll get through the process. We're dedicated to it, and keep following up. And really the contributions of the history is so important. So as a parent, never underestimate, your observations and the things that you notice with your kid, because that is just so helpful. It's really invaluable. The instincts that parents have in regards to their children, are rarely wrong and are rarely misguided. So that is just so, so important to go through as part of this process.
Wow, thank you so much, Dr. Ross. I especially love that end note. And your note about, the question is everything explained by what's going on, with the eyes. And that's something that often many parents experience, that just stops at what's going on with the eyes, and it's never gone through the whole secondary process of how our kids interpret the world. So we do have many questions, and some that have been submitted and some that's come up. So yeah, let's get rolling here. Question about clinical test for visual field. A parent asks, with the light wand and the testing areas, I know sometimes the room lights need to be off for the child. So how do you know they actually see the light versus seeing the outer band of the light, which is passing into another quadrant?
Oh, yeah. So that's a good point. We try to, with the light wand, there are different brightness settings that we can put on it. So we might sort of go full brightness and then use a dimmer target, and so on. But sometimes we need to, it's really helpful if we can, to do the next step of a formal test, because in that case, we can really control how the light's presented. We can control also the test order. And really, this is an area that I'm very interested in terms of best practices in developing new approaches to measure visual fields in children with various abilities. And it's something that I've been working with Dr. Mayer at Perkins on. And so we hope to have some new developments for you in how we measure visual fields, and some new things that we're working on. But yes, that's an excellent point.
That is so exciting to hear, because I know my son, and I've heard from many other parents, that visual fields they weren't able to test visual fields in the clinical setting for our kids. So I'm really excited to hear that there's some progress with other ways, creative ways to think about it for our kids. It's awesome. Okay, so definitely a lot of questions about strabismus. This seems to be a really hot topic in the CVI community in general. Many kids with CVI have co-occurring ocular conditions, and strabismus is definitely one of them, as you mentioned. One parent asked, I would like to know more about the relationship between strabismus and CVI. We've been patching for 8 years and we're told to continue and have not been a candidate for surgery because there is not a predictable pattern to his strabismus. I think he has improved without surgery. Is this because of improvement in functional vision, patching or strengthening, or something else? Big question.
Yeah, that sounds like a complex case. So not easy answers without knowing, the entire clinical history. But I would say in terms of patching, the considerations are kind of with each case, with each parent, and with each kid. Strabismus is really, very prevalent in CVI. The FASI article alone showed it was nearly 80% of the kids had an eye turn. And there's different also characteristics to eye turns. I think the decision about surgery may be simpler when the eye turn is constant. It's always the same amplitude. But, some eye turns are not constant. They're varying amplitude, and sometimes they're intermittent and they're not. So what makes it easier for us as clinicians, and for myself, I don't do surgery, but I would work with an ophthalmologist who does, is, for myself and the ophthalmologist to be able to talk about, well, how consistent is the eye turn? What patterns are we noticing? Does it vary if they're doing different tasks, like a close task versus another task? So the more information we know, that really helps the decision, but these aren't always easy things. So I can appreciate why it sort of puts the parent in the middle. But the more information that you can provide about trends that you notice, and some of my patients' parents are particularly good. There was one case I was really excited because they had a catalog of pictures of the eye turn and what the kid was doing at that time. And that was really helpful. And so I sort of summarized that for the ophthalmology team and presented it to them. And then that was really helpful to make the decision.
Why do you think strabismus is common co-occurrence with CVI?
I don't know, but sometimes I wonder if it has to do with the fact that often strabismus is really common in kids with cerebral palsy, and is also common in cases of premature birth, and those are also sort of the situations where CVI is common. So I wonder if it's, sort of likely that they both present together, although they're sort of separate entities. But yeah, there's a lot of investigation to try to better understand that. And if one is connected to the other, or is it just sort of coincidence that, both situations are kind of create the right formula for them to present.
Does an improvement in functional vision, improvement in that central vision in fixation of eye to object contact, have you seen that improving an eye turn over time in kids with CVI? Sorry if I'm asking.
Yes. So sorry, I just
no, it's okay.
Got a communication about a patient. So sorry for being distracted, but I would say in terms of, can improve, when you are better able to visually engage a child, does their eye turn improve? Yes, it can. Because it may be that, they aren't able to, fixate. The lazy eye might be worse, when you're tired, not able to engage. So I think that's an important aspect and an important thing to consider. And that's why I said, having the photos, if not just the photos of the eye turn, but what is the kid doing, allows us to see, are they attentive to a visual object in this photo, or are they not, or what's going on?
Got it. Do you need to check in with the patient right now?
I think we're good.
Okay. let me know. You mentioned with strabismus that if strabismus or an eye turn is present, that it can cause difficulty with visual clutter and visual complexity. Is that a common issue with strabismus?
So patients with strabismus often they'll report things run together sometimes on them. That they might report that they have difficulty following along a line when they're reading. So they do benefit from increased spacing. So they may not need things to be bigger, but they need the spacing to be a bit better between lines. So that is, a common issue. And in kids with CVI, that's there, but, it's exacerbated even more. So the spacing becomes even more of an issue. We need even more, separation or isolation. Using, line guides or even a mask, to mask things as they're reading along becomes more important.
Yeah, I mean, it's just so important to understand the effects of both the ocular conditions and the CVI to really get the whole picture of what's going on.
Yeah, and it's not always clear on the first go. And, I try to convey that to parents, and hopefully, they sort of recognize that in our visits, that this is going to be a process. This is going to be a bit of a journey. And as the kid gets older, we learn more, and we also learn how they adjust and are compensating. One of the things that is really difficult about kids with brain-based vision impairment is, the brain in kids is so plastic. It's so adaptable. They adjust in different ways. And we don't see this in adults. In adults, with stroke, it's the infarct is here, the visual deficits are X, it's the patterns are much more clear, but kids are so adaptable. So it's, which is great. They, are so able to compensate, but in so many ways that I'm always inspired and flabbergasted by, but it makes it harder to identify what's going on because it's not that clear-cut picture like it is for adults.
They figured out some ways around it. That's interesting. Yeah. Okay, question that just came in. When the ophthalmologist uses a lens for refraction and to prescribe glasses, is there a way to determine the visual acuity? And then how does this determine recommended font size?
Yeah, so certainly in terms of recommending glasses, we might go through the process of subjective refraction where we ask the patient which is better, one or two, or we might do it objectively. So looking at the light reflex through lenses until we get a neutral reflex to determine the prescription. And we are fairly good at that. We can get a pretty spot on prescription just by looking at the light reflex. Often we also have to use drops in kids so that their focusing doesn't vary as we're trying to measure this light reflex. If they're really looking up close when I'm measuring, I'm not going to have the best prescription. So sometimes I have to look, without the drops, and then I look again with the drops so that their focusing range isn't all over the place. But once I put the drops in, sometimes their vision is blurry. So it's hard for me to then put the lenses on and then remeasure their vision to see if there's an improvement. So, as in the case composite that I presented, we have to bring that patient back with the glasses on and sort of see where are things now, what improved, what didn't, and sort of assess again.
I see.
So often it requires that second visit.
Yeah, that's great. Let's see. So question about pupil asymmetry. Is pupil asymmetry connected to CVI? My son has intermittent pupil asymmetry. It is consistent in that it is the same pupil, that it is bigger each time this happens, but inconsistent in that it isn't all the time. It does seem to happen less often as he ages. His doctor saw the asymmetry just by luck because it was present that day. Other doctors haven't had the chance to see it. My son's pupils always test equal and reactive, but his pupils also always seem much larger than everyone else's in the same room and lighting.
So it's hard to say. I would say that, the pupil reflex, a large part of our pupillary response reflects the function of the optic nerve and that pathway. And sometimes, when we look at the optic nerve, everything looks okay. And sometimes we have to image it or take some additional information in order to get a better understanding of what's going on. Some patients have pupil asymmetry that's totally normal. So, if I look at a patient with pupil asymmetry and one pupil's larger than the other, but it's the same in a bright environment than a dim environment, then, that's just sort of how they are. But if there's differences in bright and dim, that might reflect optic nerve function or might reflect neurological function. And so then I'll need to do additional testing. So it's hard to answer that question without knowing more information.
Okay, absolutely. Next question about, and this really resonates with me, and I know a lot of other CVI parents. If a child is not feeling well, such as GI issues or a head cold or even just teething, how does this impact their visual processing? And is there any way to assist during that time?
Yeah, I think, for all of us, we can appreciate when we're not feeling well, it's really tough to pay attention, right? And, whether it's visually, auditory, or otherwise. And, I think the best way forward usually is in small bits, when we, for everything. So I try to break things up. I try to, give breaks and that sort of thing. Oftentimes during the low vision exam, I like to know, if the patient's having kind of a rough day and we, happen to test him on a day when they're, having a lot of GI issues or aren't feeling themselves, because that'll affect their performance on the vision test too. And, we want to look at trends over time. So it's important to note that stuff and see, how can we make them as comfortable as possible. It's a challenge I can appreciate. So no easy or obvious answers there, unfortunately. But I would say parents know their kids best.
And knowing that any type of those issues can profoundly affect their ability to use their vision.
Yeah.
It just needs to be known, right?
Right.
Great. Let's see. So let me think of other ones that came in. Can a child be diagnosed with delayed visual maturation after 9 months to 1 year, or is it CVI?
Yeah, this is a contentious topic amongst doctors in the field about what is delayed visual maturation and what is CVI. And when do we make that call? At what point is it no longer delayed visual maturation? I would say that for myself, I look for trends over time. Are things improving over time? Are things pretty static over time? Are there other factors that might affect the child's visual ability? I think in the case of delayed visual maturation, many of the recommendations and the educational supports that we make for kids with CVI are helpful for those kids too. And it's important for them to have those types of accommodations so that they can make progress. So sometimes I tell parents, like, look, I'm not sure entirely if this is just delayed visual maturation or if this might be CVI, but I think we should move forward with some of these compensatory strategies and some of these supports and see how things go so that this child has everything at their disposal to be successful. I'm of the opinion that I would rather have patients have access to every possible resource for success than to delay their access to those resources.
Absolutely. And I'm trying to look through a few other questions here. So there's another common co-occurrence with CVI is optic nerve hypoplasia, optic nerve atrophy. Something going on with those optic nerves.
Right.
Parents might report that the doctors see, small optic nerves, pale optic nerves. Why do you think these co-occur? And do you think the optic nerves are reacting to what's going on in the visual processing centers of the brain? I know it's kind of like a chicken or an egg question, or is it just kind of another coincidence thing?
Well, certainly the optic nerves are an extension of the brain, and so is the retina, really. It's all part of that neural development. So certainly if you have a large event that, like a lack of oxygen to the brain as a whole, a lot of different areas can be affected, including that optic nerve. Certainly there's also, other, as we went through, other things that can happen too in terms of the brain development for a child that can affect both the optic nerve and the brain. So because the optic nerve is an extension of the brain, it's sort of susceptible to the same type of damage that the brain is. So I think that's perhaps why they're often co-occurring, but not always. I think sometimes the challenge is, what is the visual potential of a kid with optic atrophy? It's tremendously varied, right? I have some patients who have 20/20 vision. I have other patients that are 2400 vision with optic atrophy. I have some patients with field loss, other patients without field loss. Again, the child's brain is tremendously plastic and different outcomes can happen. So it's tough because there aren't clear trends, but what you're looking at is, how can we maximize this person's visual function? How can we make sure they have all the compensatory techniques, all the potential resources available for them to be successful and do what they want to do? And just sort of adjust as time goes on, right? Is all you can really do.
Constant evaluation. I love this theme.
Yes, yeah. You gotta, I mean, the kids teach you what you need to know, right? And you've got to grow with them and meet their needs as they grow.
I love that. Another question here. Any tips for parents looking for a diagnosis for their older kid suspected of having CVI?
Oh yeah, sure. I see patients who are older often. Yeah. I had a patient who was going into college and he was, quite frustrated by his vision. He said, just doing things visually is frustrating. And he's like, I don't know why, but it's just frustrating. I don't like to read. I don't like to do this, do that. It just is difficult for me. And I can't, it was very frustrating. He's like, I can't pin it down. I can't explain to you what I experienced, but it's just ever so frustrating. And so we went through, the sort of the standard exam. Then I asked, more questions along the questionnaire, and it was, complexity was the big issue there. When things were busy or there was a lot on the computer screen or, a really noisy environment where you had to integrate a lot of things at once, that was difficult. And so then we started, taking different approaches. I said, well, how about if you, read for me this way? Where there's less on the page, there's masking and so on. Like, okay, yeah, I can do that. That's just not as frustrating. And so then we kind of went the next step. Well, how about if we do it this way? Okay, yeah, that seems to be okay. And so we just had to kind of work it through. And so this was a patient who has a diagnosis of, mild CVI, affecting his ability to integrate information. He did have a birth history, that was sort of common of our CVI patients, very complex birth history. And so, this came rather late, but now he has, a bunch of strategies in college to sort of help him. And he has also knows to seek, student resources and what resources he should be asking for, how to advocate for himself, and so on. So sometimes, we do have patients that we're making the diagnosis rather late in their student career. But I think it's always helpful to, seek those answers.
Yeah. Yeah. Can you describe some of the ways that your older patients CVI have described their vision?
There's certainly as you can appreciate, a huge spectrum of visual difficulties that patients with CVI experience. And I think that's what makes the diagnosis a little bit challenging. Visual complexity is a theme that I see very often, that integrating information being difficult. If you want me to listen to something, I'm sorry, I can't look at whatever else you're doing. I just have to listen. That sort of thing. That's a common thing I hear. I did have an adult patient who didn't actually have difficulties with complexity so much, but had difficulties with facial recognition. And so it was more of those ventral stream difficulties of recognizing and seeing how, if an object's presented slightly differently, recognizing that that's still the same object, even though they may have not seen that precise picture before.
Wow.
So the difficulties and the challenges are really varied, and I think the approach to the patient needs to be individualized to that patient. It's really helpful to know and to try to get to know your patient as best you can. What's important to them? What do they find? What are they having difficulties with? What's frustrating? What's not? What do they like to do? What do they avoid? Why do they avoid it? All of those are really, personal.
Right. There's one question that came in. Hold on. That's really good. I mean, CVI just manifests so differently with all of our kids, it's so individual.
Yeah, I think sort of the next sort of trend of work in the area of CVI has to be looking at, we've now been really good at classifying the different range of difficulties that we see. We've sort of classified dorsal, ventral, and put people in different groups. That's sort of been helpful for us to think about and understand CVI. But I think now we need to go the next step and say, okay, with these patients, with these difficulties, what is most helpful for them? What's the trend of interventions that they find most helpful? We have a whole slew of, possible interventions, but what does this particular group find the most value in? And how does that differ to this other group? I think, that's sort of the next stage of work that hopefully will help us to understand how do we better serve our patients? How do we better help them?
Oh yeah, I love it. Can you clarify, let me just read the question first. Can you clarify that it can be about clutter and complexity and contrast? Contrast issues can occur alongside clutter and complexity.
Oh, definitely. So, your contrast vision is more of that primary visual disorder, like your acuity, your field. And then, with that, you can have other secondary visual disorders, which is the interpretation of that visual information. So I have many patients that have difficulty with things of poor contrast. They need it to be bright and bold in order to recognize it. But if you have too many big, bright and bold things, that's also difficult to manage. And that can really manifest itself in visual search tasks, like finding the favorite toy in the toy box. If that's, difficult, that's more of a visual clutter type of issue. So we have to sort of think about, yes, that they can occur together. They can be, separate issues also as well.
Yeah, absolutely. I mean, that has to also go with learning media as well, in terms of bold print or certain color and print on a certain background, images and pictures. Yeah, that's really good. And then, one final question that I want to ask personally, just forward thinking, is how can we ensure that children with CVI get diagnosed? What are some of the changes that need to happen in the medical community to ensure kids are able to get a diagnosis?
Yeah, I think, just over the time I've been practicing at the Perkins Clinic, there's been a tremendous, change in discussion. Just even in Massachusetts with our local community here about, recognizing CVI. It used to be that we used to say a kid has CVI if nothing else can explain their vision impairment. And now we have an appreciation. It's like, well, if they have this, but that doesn't explain everything that's going on, we still have to consider CVI. So I think just in the last 5 years, there's been a huge shift in recognition that just like any other condition, you can have multiple conditions at the same time. You can have hypertension and diabetes, and you can have an eye condition and CVI. So there's a huge shift that's happening in the medical community. There is more emphasis in medical conferences now about discussing CVI, about discussing the interprofessional care that needs to happen, the integration of educational services that needs to happen, that we need to make sure as practitioners we are part of a team, that we're communicating with that team. So I think there's tremendous changes happening in that area and happening rather quickly, which is really encouraging to see. And so, I'm hoping that, with more, hopefully with more conferences also virtually last year, there's been more participation by everybody too, to talk about new concepts around CVI. So the tide is moving.
Good.
The tide, everything moves slower than maybe we want it to, but it is shifting, and that is encouraging.
That's great. That's wonderful. Oh my goodness, Dr. Ross, thank you so much. This has been a fabulous presentation, just a really rich discussion. Thank you to our CVI Now parents for your questions. And thank you so much for your time and expertise. I'm just so humbled to continue to learn from you.
Thank you.
We're really changing the lives of so many individuals with CVI and so many CVI families. It's just so important. I don't want to understate that, your contribution to the field. And, it's just incredibly important that, our kids with CVI have a right to early diagnosis, and there's still a lot to change. But as you said, things are moving in the right direction, and I'm just hopeful thanks to leaders like you. So thank you.
Well, thank you. I think I owe it to all my patients who I learned from them, right? And you guys and the educational professionals and everybody. And so I really appreciate, all my patients and how they contribute to helping me understand what they experience.
I love it.
And sharing that with me.
I love it. Thank you. Thank you so much.
Oh, thank you for having me. This has been great fun.
Love it. Thanks, everybody. Stay safe, be well. Have a great rest of your day.
Bye now.
Thank you so much for watching this event brought to you by CVI Now here at Perkins School for the Blind. Go to cvinow.org to learn more.